Hey, my name is Paul Wax. I'm the Executive Director of the American College of Medical Toxicology, and I'd like to welcome you to this special webinar series entitled Medical and Public Health Consequences of COVID-19. The title of today's presentation is ACEs and ARBs, NSAIDs, Remdesivir, and updates from the front lines. Next slide. Next slide. I'd like to thank all the webinar series partners who are participating in this consortium. We've rapidly brought together all the major toxicology societies from around the world and the American Academy of Emergency Medicine. And together, these 7 societies will be continuing this webinar series over the next few weeks during this public health emergency. Next slide. Next slide. This is a graph from the John Hopkins, just showing where the United States is on its number of cases. We've all seen this in the news, and it goes to show you the gravity of the situation and the importance of public health communication. Next slide. There are no conflicts of interest. At this point, I'd like to turn over the presentation to Dr. Mark Kostick. Mark is the president of the American Academy of Clinical Toxicology and a webinar participant, and he'll be introducing the next 2 speakers. Thank you.
Thank you so much, Paul, and thank you, Ziad, and thanks to ACMT for putting this together and bringing all these groups together from around the world. This is pretty exciting. I'm very excited to introduce our first speaker, who's Dr. Ryan Feldman, PharmD. He's a delegate of the American Board of Applied Toxicology and an emergency medicine pharmacist and partner of mine at the Medical College of Wisconsin and Froedtert Hospital in Milwaukee. And Ryan is a brilliant pharmacist and clinician, and he's going to speak to us today about nonsteroidals and the conflicts regarding COVID and nonsteroidals. Ryan, thank you.
Thank you, Dr. Kostick. Okay, next slide, please. So today I want us to understand the role of ACE2 and SARS-CoV-2 viral entry. We're going to understand the impact that NSAIDs might have on ACE2 and then discuss the role that NSAIDs could play in COVID-19 disease severity. Next slide. So it really starts in the year 2000 when we discovered this very important enzyme, angiotensin-converting enzyme 2, the counter-regulatory enzyme 2, ACE, which we all know very well, converts angiotensin 1 to angiotensin 2, the inflammatory and vasoconstrictive molecule. ACE2 cleaves angiotensin 2 into angiotensin 1,7, an anti-inflammatory and vasodilatory molecule, so a counterpeptide to angiotensin 2. Next slide. So in 2003, it was discovered that ACE2 is actually the docking site for SARS-CoV-2 spike protein, the protein it uses to get inside the cell. And around January of 2020, it was determined that ACE2 is most likely the protein that SARS-CoV-2, this viral strain, uses to get into the cell, along with possibly a few others. Next slide. So on March 11th of 2020, there was a letter to the editor published in The Lancet, where the authors observed that fatal cases of COVID-19 frequently had conditions that were treated with drugs that can increase ACE2, like coronary heart disease, diabetes, and hypertension. Despite the fact that these are also diseases that are largely found in an older population, and we do know that older age is a risk factor for mortality, the authors postulated that the drugs that are increasing ACE2 might increase your total disease burden, and that would be drugs like ACE inhibitor, ARBs, and ibuprofen. Next slide. There's actually quite a few things that can modulate our ACE2. So some things like angiotensin 2 can actually decrease ACE2. Certain diseases like inflammatory conditions and diabetes can decrease ACE2 or increase it. And then many different drugs, NSAIDs, thiazolidinediones, ACEsARBs, and mineralocorticoid antagonists. Next slide. So On March 14th, the French Minister of Health released a tweet that started really this whole cascade and said taking anti-inflammatory drugs like ibuprofen or cortisone could be an aggravating factor in COVID-19, and you should use paracetamol, or here in the States, acetaminophen, to treat fever. The World Health Organization spokesperson was then questioned on both the tweet and the prior Lancet letter to the editor and said, well, we're not entirely sure, but you should probably take acetaminophen until we know more. And less than 24 hours later, they came out with a statement saying, no, actually, we do not recommend against the use of ibuprofen. But we have large organizations like the NHS, which says, no, there's no current evidence, but you should probably avoid using ibuprofen until we know more. And the FDA says, well, we're looking into it, and we'll let you know what we find. Next slide. So with all these kind of conflicting guidelines, it's no wonder that there's confusion about this. And when you add in a little bit of viral misinformation, like this post stating that everybody who was dying had ibuprofen in their system, you can see why Tylenol is now being purchased off of store shelves faster than it can be produced. Next slide. And so now we're going to try to figure out what exactly is going on, and we can go to the next slide. So the authors of the Lancet were correct that it is biologically plausible that NSAIDs could increase ACE2. We know that NSAIDs block cyclooxygenase, which prevents arachidonic acid from being metabolized into prostaglandins. Those prostaglandins initiate renal renin secretion, and if we block that, we don't get an increase in angiotensin 1 or angiotensin 2. And thus, as you know, angiotensin 2 can downregulate ACE2. So if we don't have any angiotensin 2, ACE2 might upregulate. Now, acetaminophen, some will also say, is a non-steroidal anti-inflammatory, but it only works on cyclooxygenase in the central nervous system. So ideally, it shouldn't be affecting the kidney and shouldn't be increasing ACE2. Next slide. Now, this is supported by animal trials. So if you take rats and induce an inflammatory arthritis in them and randomize them to either NSAIDs for 7 days or nothing at all, you can see that inflammatory arthritis decreases ACE2 more so than control. And NSAIDs treating the inflammatory arthritis blunts that reduction in ACE2. But if you look at the ACE2 levels, they don't appear to be that much change from the control group itself. So it's really not clear what effect NSAIDs would have on a healthy control that didn't have an ACE2 decreasing condition in the first place. Next slide. And this has also been shown in animal models of rats given diabetes and randomized to ibuprofen for 8 weeks, control or pioglitazone. You see largely the same thing. Diabetes reduces ACE2 compared to control, and ibuprofen blunts that reduction in ACE2, although their ACE2 levels aren't even at the same as control in certain tissue. So it's not clear that NSAIDs necessarily increase ACE2 to degrees greater than a normal person would have circulating. Next slide. And even if they do increase ACE2, how does that impact COVID-19? So how does ACE2 upregulation have an impact here? Next slide. Well, some think that ACE2 upregulation could increase infectivity. If you have more receptors for nCoV-19 to dock on, you're more likely to have more virus either collide with the receptor or enter the cell. Next slide. So as you can see here, I have more ACE2 receptors, I can have more nCoV-19 attached. Next slide. But it's not always the case that upregulation is good for viruses. In fact, some use downregulation to enable their propagation. So HIV actually secretes a downregulating Neph protein when it attaches to its docking protein. And this helps HIV get into the cell by endocytizing the receptor, and it might prevent superinfection with other strains of HIV that are trying to get in, and it would have to then compete with for viral replication. So we don't know if that would be a benefit for SARS-CoV-2, but we do know that when SARS-CoV-2 attaches to ACE2, it downregulates the receptor. And there is theory that this could actually worsen disease in COVID-19. So next slide. So normally, we have, yep, we can see right on the slide. Normally, if we have downregulated ACE2 and they're fully occupied by nCoV-19, as you can see on the left there, we don't have any ACE2 available to metabolize or to cleave angiotensin 2 into the anti-inflammatory angiotensin 1/7. So we get increased inflammation and increased pulmonary damage. And as you know, a lot of these COVID-19 patients have high levels of interleukin-6 and they're very inflammatory. As opposed to if I have upregulated ACE2, even if I have some occupied by the nCoV-19 virus, I might still have some available to cleave angiotensin 2. And I might even have increased soluble ACE2 that can actually intercept nCoV-19, the viral vector, before it reaches the cell. Next slide. And this is actually supported in animal models. If you take rats with influenza, rats who have no ACE2, who cannot metabolize any angiotensin 2, have much worse pulmonary damage than control rats. And you can actually reduce the pulmonary damage by administering soluble ACE2. This has also been shown in rats with acid-induced lung injury. If you give them SARS-CoV spike protein, you can downregulate their ACE2 and actually make the acid lung injury worse. Next slide. So for this reason, a variety of authors have actually postulated that you could use a drug like losartan in order to increase circulating ACE2 levels and maybe prevent the damage from COVID-19, or get soluble ACE2 to act as a receptor-interceptor for the virus and prevent it from reaching the cell. Next slide. So what do we actually know? It's theoretically possible that NSAIDs can increase ACE2. Animal experimental data supports this. The theory, its mechanism is in line or is consistent with what we know about NSAIDs and the RAS system. But the animal studies that this was done in were all with more than 7 days of exposure, and they were all confounded by diseases that modulate ACE2 already. So it's not entirely clear what the impact of infrequent NSAID use is on healthy individuals with no other pre-existing conditions. And animal data does not equal human experimental data. So there is no real human data looking at ACE2 levels after NSAID exposure. And we know that some drugs like ACEs and ARBs have shown a positive impact on ACE2 in animal studies, but variable effects in humans. Then in the end, we really don't know how ACE2 regulation modifies disease in any way, positive or negative. All we currently have are theories, and theories are frequently dispelled with good scientific testing. So what we need to look at are clinical outcomes amongst patients who have taken NSAIDs or any ACE2 regulating drug for that matter, and determine if their COVID-19 disease severity is worse than those who have not been exposed to them. However, no randomized controlled trials exist on the use of NSAIDs in COVID-19, by no surprise, and no studies are registered with clinicaltrials.gov to evaluate NSAID use. And additionally, no COVID-19 cohorts or interventional studies or observational trials have described the degree of NSAID exposure that the patients have had. So we're kind of at a loss for data at this moment. So while we don't know at all really how NSAIDs will impact the disease severity of COVID-19, we do know about their risks that they've always had. Next slide. So unfortunately, don't have a ton of time to dive into this, but NSAIDs carry a variety of risks that we've known about for quite a while. So if you block cyclooxygenase, you can shunt arachidonic acid down the thromboxane pathway and increase platelet activation. So all NSAIDs carry a black box warning for increased thrombosis, and there is epidemiologic data to support that patients who have upper respiratory infections and take NSAIDs are at an increased risk for stroke or MI, which is certainly concerning given that some of these patients with COVID have cardiac involvement as well. There are concerns also about increased complications. If you block cyclooxygenase entirely, then you shunt arachidonic acid down the lipoxygenase pathway and make glucotriene. And as you know, we target that in asthma patients to try to reduce inflammation. So if you give NSAID, there is a small amount of the population that can get NSAID-induced bronchospasm, as well as there's some case cohort studies that have demonstrated increased empyema in children who are using NSAIDs for upper respiratory infections. So we have some kind of nastier side effects just from their class itself, as well as our effects on the gastric system and renal system that we've known about. So is there some large benefit of NSAIDs over acetaminophen in order to make us want to use them more in upper respiratory infection? At least in one trial of almost 900 patients, there's no significant difference between Tylenol and ibuprofen in symptom reduction. So it's not really clear that there's a huge benefit for them. And then lastly, next slide. So it's probably too early as a takeaway to change NSAID prescribing due to COVID-19 theories. We need more clinical data, and patients who are on NSAIDs like aspirin for cardiovascular risk reduction or taking something for gout or osteoarthritis should likely continue taking them, and if they have concerns, maybe raise them with their primary care provider. And NSAIDs are a viable option for patients who need fever or pain treatment during this disease, but we do need to be aware of their current risk profile. So patients who are at low risk for adverse effects might still be a benefit. You know, ibuprofen, I believe, is approved for 6 months and older, so a 6-month-old is unlikely to experience some of those more significant adverse effects. Or somebody who can't tolerate acetaminophen or needs something for breakthrough. Or if all of your Tylenol has been bought off the shelf, it should still be a reasonable consideration to use ibuprofen. But we might want to avoid it in patients who have advanced stage history of thrombosis, gastric bleeding, peptic ulcer disease, asthma, or renal disease. There's some additional resources listed on that slide. I know I've gone over time, so I apologize. References are listed alphabetically after this if anybody wants to pull any of the studies that were cited. And now I'd like to hand off to the next speaker. Thank you very much for your time.
Thank you, Ryan. This was a really nice, detailed explanation of all of these, information that we're hearing on the news and media. Our next speaker is Dr. Josh King, Assistant Professor of Medicine and Pharmacy, Medical Director of the Maryland Pogen Center, Associate Program Director of the Nephrology Fellowship, University of Maryland. Dr. King, I will move the slides for you.
All right, thanks, Ziad, and hi, everyone. Thanks for having me talk. I'm not going to retrench the entirety of the angiotensin 2 and ACE2 physiology that Ryan nicely detailed, but you can see here that, as mentioned, ACE2 is the point of viral entry for novel coronavirus, and as he mentioned, ACE inhibitors and angiotensin receptor blockers upregulate ACE2 levels. Next slide. The SARS coronavirus 2, the novel coronavirus, uses membrane-bound ACE2 as an viral entry point, following which the coronavirus enters the cell and actually leads to downregulation of ACE2 thereafter. And there was a nice review published just 2 days ago in New England Journal. Next slide. It's not clear whether or not, as Ryan mentioned, ACE2 downregulation or upregulation is helpful or harmful. This is a model with the original SARS coronavirus where rats were given acid lung injury and angiotensin 2 levels increased with administration of the SARS coronavirus spike protein. After losartan was administered, that lung injury was somewhat ameliorated. Next slide. We'll skip this as Ryan mentioned it. Next slide. So we're left with a conundrum. Is ACE2 harmful or helpful? On the right side, where ACE inhibitors and angiotensin receptor blockers themselves could be harmful, the hypothesis is that less ACE2 is good. And there's a lot to suggest that. ACE2 upregulation may lead to more viral entry. We know that at least that olmesartan, although other ARBs did not show increases of ACE2 in the gut, may increase the fecal oral spread of the novel coronavirus. Having decreased level of ACE2 on cells from angiotensin 2 presence may improve outcomes through having less viral entry. And there is an anecdotal benefit of angiotensin 2 used as a pressor in COVID. But on the left side, considering the possibility that ACEs and ARBs may actually improve outcomes in COVID patients, is that angiotensin 2 itself, as shown from that rat model, is implicated in lung injury, although it's not certain whether it's angiotensin 2 itself causing lung injury or downregulation of ACE2. Angiotensin receptor blockers lead to more ACE2 on cells, which improves lung injury in other animal models as well. Patients taking ACE inhibitors have general generally improved pneumonia outcomes. This is not viral pneumonia, this is all-comer pneumonia. So there may be something to this ACE2 being lung protective. And lastly, if ACE2 levels, if ACE2 is harmful, then one would expect improvement in outcomes as opposed to the novel coronavirus downregulating ACE2, decreasing levels and causing severe lung injury. So there's hypothesized evidence for both, but unfortunately no real clinical evidence. Next slide. Just about every hypertension society has come out and said that patients taking ACEs and ARBs should not stop their drugs. And the reason is that, as mentioned, it's unclear whether or not ACEs and ARBs are helpful or harmful for novel coronavirus. But it is very clear that ACEs and ARBs have benefits in heart failure, hypertension, chronic kidney disease, and a host of other conditions. These are drugs where millions of patients are prescribed for conditions that may ultimately be more detrimental to them than novel coronavirus if they should stop their drug for fear of having an increased risk of severe disease or increased risk of contracting novel coronavirus. Next slide. There are several ongoing trials. 3 observational that I'm aware of that are registered at clinicaltrials.gov, one in Italy, one in the UK, and one in Wuhan, China, that look at patients taking ACEs or ARBs and their outcomes from COVID. There are also 2 investigational trials, both being performed by the same group in Minnesota, where losartan is actually being used as a therapy for COVID. And those are for the reasons detailed before in the possibly beneficial slide. Next slide. Lastly, I just want to mention the question of whether or not angiotensin II should be used as a pressor in COVID. There's an opinion paper that was published 4 days ago, actually by folks in my institution, University of Maryland, as well as a preprint paper that came out a few days ago that looks at the possibility of ARBs improving outcomes. Next slide. It's thought that angiotensin II deficiency may be involved in shock induced by COVID. And one of the hypotheses is that administering angiotensin II to these patients may improve outcomes in viral-induced cardiomyopathy and cardiogenic shock, which is becoming increasingly clear plays a role in some patients' deaths. Next slide. But there's also a retrospective review of patients who have COVID in China, a small review. Next slide, and then the slide after that. That looks at a total of 46 patients who are elderly, who are on angiotensin receptor blockers and other antihypertensives, and looks at their outcomes. It shows a promising improvement in a grand total of 10 patients, where 3 patients who were taking ARBs developed severe disease and 7 who were taking them developed mild disease. I personally don't take this for much because the sample size is likely too low to generalize. Next slide. So I think it's uncertain whether ACEs or ARBs worsen or improve outcomes of COVID, and it's uncertain whether angiotensin II is an additional benefit. And because of this, patients who are currently taking these drugs should probably not stop therapy until trials help to determine whether or not ACEs and ARBs are harmful, helpful in COVID, or neither. Next slide. This has been actively debated within the nephrology community, and I would encourage you to go to the website of the Nephrology Journal Club, nefjc.com, where there's a fantastic resource guide. Thanks all for having me talk.
Thank you, Dr. King. Moving along, we keep questions till the end. We have Dr. Matt Davis, who's a PharmD and infectious diseases pharmacist at UCLA Ronald Reagan Medical Center. Dr. Davis will talk about Remdesivir, a review of pertinent drug for SARS-CoV-2. Dr. Davis, I made you a panelist, and you should be able to go ahead and speak, and I will move the slides for you.
Thank you. Can you hear me?
Yes, very.
Okay, next slide, please. So I'm going to briefly talk about remdesivir. I only have 10 minutes, so I'm going to leave out a few slides here and there. But just jumping into it, mechanistically, remdesivir is an antiviral that inhibits viral RNA-dependent RNA polymerase, and this leads to premature termination of viral RNA transcription. It is an investigational drug, and phase 3 clinical trials are ongoing, and it is formulated for intravenous use only. For dosing in adults, there's a loading dose of 200 milligrams on day 1, and this is followed by 100 milligrams IV daily for 5 to 10 days thereafter, depending on the clinical trial that the patient's enrolled in. Next slide, please. So looking at the structure of remdesivir, it is a monophosphoramidate 1-cyano-C-adenosine nucleoside analog, and I wanted to highlight a few key points about the structure-activity relationship. Next slide. So let's focus first on this monophosphoramidate group. Next slide. So here I have for you 3 variations of nucleoside analogs with different 5' substitutions circled for you in green. On the left here, we see the hydroxylated form. And for antiviral activity, this hydroxylated form needs to be phosphorylated by intracellular kinases. And unfortunately for these nucleoside antivirals, they have to compete with endogenous nucleoside pools. And this is a rate-limiting step for antiviral activity. Now, looking at the middle structure here, we see the monophosphate form, which circumvents this initial rate-limiting phosphorylation step. However, because this phosphate group is negatively charged, it does impede its ability to traverse cellular membranes and get intracellular, where the antiviral needs to act in order to combat viral infections. So on the right here, we see remdesivir, which has a phosphoramidate moiety attached. And this mitigates these 2 concerns. First, the phosphoramidate group is neutrally charged, so it has no issues crossing the cellular membrane. Secondly, once it is intracellular, it is cleaved by esterases to the monophosphate form. And this circumvents the need for this rate-limiting phosphorylation step. Next slide. So looking at the 1' cyanomodification, I wanted to focus on a few points there. Next slide. So when we first looked at the C-adenosine analog for antiviral activity with no modifications at the 1' position, it did have poor selectivity and was highly cytotoxic for the cell lines under study. However, when the 1' cyano group was added to that position on the right here with remdesivir, it did show significantly increased selectivity for viral RNA polymerase's active site, and this subsequently reduced the cytotoxicity in the cell lines under study. So this conferred high selectivity and increased the therapeutic index. Next slide. Just a few key points for pharmacokinetics of remdesivir. It is 12.1% unbound by plasma proteins and is widely distributed throughout the body. It is metabolized from the phosphoramidate prodrug by esterases and carboxypeptidases intracellularly. It is eliminated partially via renal and hepatobiliary elimination. And then a few key points on the PK parameters at the table at the bottom. We can see the remdesivir prodrug form has a very short half-life because it is rapidly converted to the active nucleoside metabolite in the body. The active metabolite peaks at around 3 to 4 hours, and it does have a long intracellular half-life, around 20 to 25 hours, which supports the use of once daily dosing. Next slide. So for safety, in phase 1 clinical trials and multiple dose studies, it has been generally well tolerated. The most notable adverse event reported so far is transaminitis, with an onset ranging from 5 to 25 days and resolution 3 to 47 days thereafter. And this has prompted the transaminase-based exclusion criteria in the ongoing clinical trials. I've listed the other adverse events that were reported there for you. Next slide. And just a few other key points. Remdesivir does include the cyclodextrin solubilizing agent with either 4.5 to 9 grams, depending on the formulation of 150 milligram remdesivir that you receive. And for comparison, 400 milligram IV voriconazole dose includes 6.4 grams of cyclodextrin. However, the actual clinical significance of cyclodextrin in humans is still up for debate. As far as the hazardous compound statement that was available in initial pharmacy manuals, the NIOSH and ASHP, or Gilead has clarified that remdesivir does not, in fact, meet NIOSH or ASHP criteria for a hazardous compound and does not need to be made in a chemo hood. Next slide. So remdesivir has been tested against a number of different viral RNA families, including Ebola, MERS, SARS-CoV-1, and SARS-CoV-2, and I'm focusing on the in vitro activity of these four. Next slide. So first and foremost, since the majority of us are probably unfamiliar with some of these virology terms, I'm going to briefly define them for you. So the EC50, or the effective concentration 50, is the concentration required for 50% maximal inhibition of viral replication. And this is the parameter for efficacy or potency. The CC50, which is the cytotoxic concentration 50, is the 50% or half maximal concentration required for cytotoxic activity for the cell lines under study. And this is a parameter for toxicity. And then the selectivity index is a ratio between the two, with a higher index translating to a wider therapeutic index and a higher selectivity for viral RNA polymerase in the case for remdesivir. So looking at the EC50 specifically for SARS-CoV-2, we see that it does have a submicromolar EC50, which is generally accepted to be highly potent in vitro activity. Next slide. So this is in comparison to the other agents that are being investigated for SARS-CoV-2, including the nucleoside analogs ribavirin, penciclovir, and favipiravir, which all have relatively high EC50s, and then also the hydroxychloroquine and chloroquine families, which, similar to remdesivir, are highly potent in vitro. Next slide. So why do the other nucleoside analogs seemingly have poor in vitro potency? This could potentially be explained by the proofreading process that happens in coronaviruses. They each carry an exoribonuclease enzyme that will proofread the viral RNA transcript and cleave out these nucleoside agents. However, remdesivir appears to escape this mechanism either by directly evading the exonuclease enzyme itself or conferring high fitness costs on viral mutant strains. Next slide. So I don't really have too much time to get into the animal data, so I'm going to advance 2 slides, but these slides will be available for your reference later. Next slide, please. I just wanted to include this quote from one of the articles that I've included. A drug that inhibits viral replication may be of little use once viral replication has reached its peak. And I want to make a note that although we don't have a fully comprehensive understanding of the viral kinetics of SARS-CoV-2 and COVID-19 quite yet, it is biologically plausible that we can maximize benefit with antivirals, especially remdesivir, with early administration. Next slide. Just wanted to briefly touch on the randomized controlled trial that included remdesivir for the treatment of Ebola. This was a 4-arm study with ZMapp, which is a triple monoclonal antibody included as an active comparator. And remdesivir was one of the 4 arms. It was dosed at 200 milligrams as a load with 100 milligrams daily for 9 to 13 days thereafter, similar to how we're dosing it for COVID. Next slide. So the 4 arms each had a similar duration of symptoms prior to enrollment, and each arm had a similar viral load at baseline as well. Notably, there was a significant correlation between onset of symptoms and enrollment and mortality benefit, or decreased mortality or increased mortality. Baseline characteristics were generally well matched amongst the 4 arms, with numerically higher serum creatinine and LFT values in the ZMapp and remdesivir arms, potentially a signal that these patients were sicker at baseline who were already manifesting end-organ manifestations of disease. At an interim analysis, the ZMapp and remdesivir arms were halted because of a clear mortality signal, and you can see the increased mortality of these 2 arms in the survival curve on the right. Next slide. And this begged a few questions for remdesivir's efficacy. First and foremost, was the treatment initiated too late into the disease? The latest start date in animal models prior to this study was day 3. Was there potentially a flaw in the animal models under study in the previous in the animal models for Ebola that had a seeming discordance with somewhat promising data from the animal models and somewhat underwhelming data for remdesivir in humans. And then also, did the standard of care or resources impact each treatment arm equally? This trial was notably disrupted multiple times because of militant groups in the area. Next slide. Okay, I just wanted to highlight a few cases that we've seen remdesivir used in that have been published recently. So this case report was published in New England Journal of Medicine, and it was the first U.S. documented case. It detailed a 35-year-old male with no significant past medical history presenting after recent travel to Wuhan with cough and fever. He sought care at an urgent care clinic, and they decided to test him because of his travel history for SARS-CoV-2. The following day, his test came back positive, and the decision was made to admit him for observation. And then on day 10 of his overall illness, while he was hospitalized, he had a notable desaturation event to 90%. Chest x-ray showed it a left lower lobe opacity, and antibiotics were initiated. The following day, a repeat chest x-ray demonstrated streaky opacities, suggesting an atypical pneumonia. He was placed on supplemental oxygen, and his repeat SARS-CoV-2 test was still positive. The treatment team decided to initiate remdesivir compassionate use out of reports of rapid clinical deterioration in patients with COVID. And then the following day, he defervesced and his supplemental oxygen requirements decreased, and he was able to wean off to room air. However, this was way too rapid of an improvement to be attributed to remdesivir therapy, and we can't really glean too much from an efficacy standpoint regarding remdesivir for COVID just on this case report alone. However, the patient did tolerate remdesivir therapy. Next slide, please. So this second case was just published 2 days ago, and it was the first documented community transmitted case in the United States. It highlighted a female in her 40s with flu-like illness for 3 days presenting to a hospital. Notably, she had no known risk factors, either travel or contact with any known COVID positive patients. And then over the next 48 hours of her hospitalization, she had a rapid decline in her pulmonary function, leading to ARDS and requiring intubation. She was transferred to UC Davis Medical Center for ECLS evaluation. She was placed in prone position. She was paralyzed and then initiated on vasopressor therapy. Subsequently, the treatment team requested SARS-CoV-2 testing. However, this request was denied because she had no known risk factors. And then following this, a respiratory viral panel and bacterial cultures were returned negative, and the team again requested SARS-CoV-2 testing, and this time it was approved because there was no other underlying etiology to explain her respiratory compromise. Subsequently, her test came back positive, and then the team decided to initiate compassionate use remdesivir. Impressively, they actually were able to initiate remdesivir within 36 hours of a compassionate use request, which is much shorter than most centers have been able to do. Over the following 10 days, from day 11 to 20, she was treated with remdesivir. She was able to be extubated and downgraded to floor status. And then following her treatment with remdesivir, her repeat SARS-CoV-2 tests were negative 24 hours apart on 2 days. And then she was subsequently discharged from the hospital with no oxygen requirements. So once again, this is just a single case report, and we can't really make an assessment of efficacy of remdesivir therapy based off this data alone. However, the patient also did not have any notable adverse events reported for remdesivir therapy. Next slide. So in conclusion, the current data to date is still insufficient to draw definitive conclusions as far as remdesivir's efficacy for COVID. It is seemingly well tolerated in the published case reports that are available so far, and clinical trials and compassionate use are ongoing. Next slide. So here are just a few of the, or here are the clinical trials that are ongoing for your reference. Next slide. And here are my references for you to look at. Next slide. And thank you very much for your attention.
Thank you. This is great. Sorry we rushed you a little bit. We had some technical problems today. But of course, all these slides will be available shortly after the webinar, within 24 to 48 hours on our website. Recording of the actual session future and also forward to others. This is the conclusion of the remaining time will be used for a update from the field. This is a weekly update that we promise to bring you, and we will move around the world as we all go through and fight this pandemic. For this week, we have three colleagues from Italy, Dr. Davide Lonati, who's the General Secretary of the European Association of Poison Control Centers and Clinical Toxicologists. He's also Director of the Poison Control Center and National Toxicology Information Center in Pavia, Italy. We will also have Dr. Alex Manini, who's a professor in the Division of Medical Toxicology in the Department of Emergency Medicine at the Icahn School of Medicine at Mount Sinai, New York City, as well as Dr. Cameron Kyle Sidell, who's a lead intensivist in the critical care medicine specialist and university physician at the Maimonides Medical Center in New York City. We will start with Dr. Davide. There will be no slides at this point. They will share with us some of their experience and observations. I apologize, though, but we will probably have to stay 10 more minutes beyond 4 o'clock Eastern time. If you have to disconnect, we understand, but if you're able to stick around, please do, and the recording will be available for those who can't at a later time. Dr. Davide, would you like to start by presenting the situation in Italy?
In Italy, thank you very much for the opportunity to share with you and with all of you our experience. Is a very Italian drama that is taking place in other country, in another European countries such as Spain at the moment. I work at Pavia Poison Center, and also our work is changing in this month because we manage patients more or less directly involving in COVID-19 infection, and we are working on prevention of the intoxication in this particular moment, and the new therapies that are offered to the COVID-19 patient. Some intoxication in this period, some seems to have disappeared. People take fewer substances of abuse, for example, or despite a problem, they do not go into the emergency department, probably for fear of infection, and we will see. As EAPCCT, we establish a specific working group that will work on these topics. And now I start briefly with a description of our situation. In Europe and in the United States, I think it is already too late to repeat the China and South Korea model with the aim to contain COVID-19 in its infancy. Because in 1 month in Italy, from February 21 to March 22, my country went to from the discovery of the first patient COVID-19 case to a government decree that prohibited to the whole movement of the people within all the country and the closure of all non-essential business activity. In my geographical area in which COVID-19 is endemic, for example, Lombardia, Piedmont, and Veneto, almost all the routine hospital activity are stopped except for emergency, and the same for scientific teaching activity, and all school, university are closed, and in my opinion, will remain closed for months, probably will not reopen this year. And within this very short time period, Italy has been hit by a tsunami characterized by an incessant stream of death. Some aspect of this crisis may be due to the bad luck, probably is sfortuna in Italian language, and due to other aspects, however, are emblematic of the serious difficulty in recognizing the power of the threat posed by COVID-19. In general, threats such a pandemic that evolve in a non-linear way are especially tricky to compare because of the challenges of rapid interpreting what is happening in real time. And the most effective time to take strong action is extremely early, when the threat appears to be small, or even before there are any cases. As reported by experts, the important message is avoid partial solution. The Italian government dealt with the COVID-19 pandemic by issuing different decrees that increase restriction within lockdown areas, and finally to entire country. It was inconsistent with the rapid exponential spread of the virus. An example, when the government announced the closing of the northern Italy, a movement of people to the southern Italy started, spreading the virus to the region where it had not been present. Then, an effective response to the virus needs to be managed as a coherent system and action taken simultaneously. Well, now, dealing with the health aspect, I tell you that the Italian health system has been shown to be able to change and very quickly, and it is a model to follow. The main problem is the lacking of adequate personal protective equipment, PPI, for operators. This is the most important because now the infection is moving inside the hospital and many operators are positive and are virus vectors, also for their family. In fact, the percentage variable from 10 to 20% of positive cases of COVID-19 is a medical nurse personnel, and mostly in the more interested geographical areas. And the stockpile of PPI was not sufficient to protect in optimal manner all the staff. Considering only Lombardia that has 10 million of inhabitants, today we have approximately 1,500 COVID patients in intensive care unit and approximately the same number in sub-intensive department with non-invasive respiratory support, and the 40% of COVID intensive care patient is aged between 50 and 64 years old. Although the intensive care unit have doubled or tripled or more their beds, using also the operative rooms and their support equipment. In March, for example, Lombardy had around 800 ECU beds for all the Lombardy region. And during the last 5 weeks, ECU team treated 2,400 patients. Of these, around 600 died. So Lombardy basically doubled ECU unit, but the capacity only for COVID-19, but we still have something like 200-300 COVID-19 negative patients with other disease in our intensive care ward. In every hospital, several medical departments, oncology and pneumology, have been converted into COVID-19 unit with mechanical ventilator or non-invasive respiratory support. And some hospitals are rapidly building new intensive care unit department, using also room or buildings that were dedicated to teaching, training courses or other activity. And in some cities, for example in Milan, both the public health and private hospital are preparing new COVID ECU department, mostly in buildings that are normally used for trade show, for example. It's not, now in Milan is available after 10 days of hard work in the shed of the exhibition center, an hospital with 600 new beds for ECU, and a similar approach, I think, has been made in London in University, for example. At present, morgue are full and funeral are not permitted. In Italy, we registered a 10% mortality rate, which is much higher than in other countries. For example, the fatality rate in Germany is 0.9, is strange. This data is referred to the absolute mortality. And a paper published in JAMA recently, which compared the case fatality rate in Italy versus China in the different age classes, demonstrated that the case fatality rate in Italy is exactly the same as in China until the age of 70 years old. The Italian population is probably the second, the older population in the world after Japan. And we know that the population of asymptomatic carriers or patients with little symptoms is it's much larger. The phenomenon is only the tip of the iceberg, but the real problem is for contagious reasons is that is a huge part behind that we don't see. epidemiological data reported that in two neighboring Italian regions, Lombardy and Veneto, I have only 2 minutes more, allow to make some consideration, in particular about mortality rate. As reported by Italian Ministry of Health, Lombardy, at the end of March, it held to grim record of nearly 35,000 novel coronavirus cases and 7,000 deaths in a population of 10 million inhabitants. Veneto, by contrast, fared significantly better, with 7,000 cases and 287 deaths in a population of 5 million, despite experiencing sustained community spread early on. The infectious performance on these two very close regions have been shaped by a multitude of factors. The main factor is that Lombardy's greater population density and higher number of cases when the crisis explodes. But it's becoming increasingly apparent that different public health choice made early in the cycle of the pandemic also had an impact, a very important impact. Specifically, while Lombardy and Veneto applied similar approach to social distancing, Veneto took a much more proactive tack toward to contain of the virus. Then, it is currently the approach. It is currently the approach that I suggest and that I hope may help our colleagues around the world. From our experience, it is important to do aggressive testing and contact tracing, and the effort is if to apply the curve to allow hospital to be able to receive and treat the patient to the best. In the end, and I think that our life must not go back to being like before the COVID emergency. We were not ready. We were not ready for this, and we must be ready in the future. But be learning, we will all have to improve. To conclude, I would like to thank all those who have helped Italy so far. Thank you very much.
Thank you, Dr. Lonati, for this update. Moving along with our next update is Dr. Alex Manini from New York. Alex?
Hear me?
Yep, go ahead.
All right. So I've been asked to speak briefly about my experience working in the emergency department at Elmhurst Hospital, which is in Queens, New York. And it's been called by many as the epicenter of the epicenter. My first disclaimer is that this will not be very talk heavy or technical at all, so I apologize in advance. And my second disclaimer is that I'm not involved really in any of my hospital's ED operations team, so I can take no credit at all for the amazing implementation of so many disaster protocols in my hospital system. Just the way I'm going to organize my comments, I thought it'd be useful for a lot of you to just talk about the timeline of what I've seen anecdotally as part of my experience, and then to talk about some of the critical care issues that are unique to COVID, the challenges that we've faced as a group, and some of the coping strategies that we've gone through. So 3 weeks ago, we started noticing at my hospital patient chief complaints were changing, and we overhauled our ED for airborne isolation of 2/3 of the entire ED physical space in order to counter that. About 2 weeks ago, we then noticed that we had to revise our patient flow because we weren't able to keep up with the amount of COVID patients. And what we ended up settling on were 4 zones: a sorter zone out front, who could dispo patients either to a tent for further testing out in front of the hospital space or to home, or into the ED for urgent evaluation. And then from there, we had 3 more levels of care: the urgent evaluation, where we could decide whether or not patients could be sent home or admitted; a second COVID OBS area for patients who were sicker, who were on high flow oxygen or CPAP, and who potentially could deteriorate; and then a critical COVID space, which actually took over our entire trauma bay, our entire resus bay, and our entire area of the fast track, which we completely just got rid of. Over the past week, our flow has continued to increase in terms of critical patients. Yesterday, when I was working, there were 31 COVID patients on ventilators in the area where we used to have 7 resuscitation beds. We're working on moving our pediatric emergency department completely out of the hospital to make space for COVIDs. And we're starting now over the past week to rotate in off-service providers from pediatrics, internal medicine, surgery, even dermatology is getting involved, if you can believe it. One bright spot was that we were able to extubate our first COVID patient after 2 weeks that patient had on a vent. My update from yesterday is that we've had one more. So really just 2 extubations from our critical COVID patients over this past 3-week period, which is just 1 or 2 bright spots amongst all the carnage. So what I want to talk about is the critical care that I've had to learn. I'm no intensivist. Some of the challenges that you have to learn taking care of these patients are a new intubation protocol. So now there's no more bag, valve, mask ventilation. It's all CPAP pre-oxygenation to minimize aerosolation. You have to know how to place the filters, where to place the filters so that the staff are safe. You have to preset the ventilator post-intubation to assist control rather than bagging the patient to check for end-tidal CO2. You have to be very aware of use of a bougie. Some providers also like to use a plexiglass intubation setup to minimize spray or aerosolation of a patient directly into the provider space, and fewer operators during intubation. Other critical care issues are use of CPAP rather than BiPAP, awake proning of patients who are soon to decompensate, which seems to help recruit the lungs. And actually, we have a handout on awake proning that we pass out in our COVID OBS area, so that patients who are still, not intubated yet can actually engage themselves in an awake proning process to recruit. And then also use of the APRV setting on our ventilators, which is airway pressure release ventilation. And I'm no intensivist, but apparently this maximizes the amount of time on CPAP for patients. And so having our respiratory technicians help us out with setting up APRV settings, which seems to recruit the most amount of lung. Of course, we have new ventilators. So, as providers, we've had to figure out how to work new makes, new brands of ventilators, all sorts of different HEPA filter connections, and even consider doubling patients up on ventilators, although we're not doing that in the emergency department because once you've got a doubled up ventilator, it's very difficult to transport either one of those patients. So I doubt that we're actually going to get to that point. Some of the challenges that we're facing now with so many critical COVIDs in our ED, obviously PPE allocation has become an issue, and self-service of PPE is a thing of the past. So now there's a PPE ready room, which has been converted from our old family room, and it has security guards standing there, and there's somebody with an ID badge scanner so that each provider only gets 1 set of PPE for the day, and you can't double dip. We've also come across challenges with ventilator shortages, obviously, and so we've all had to make ourselves familiar with different brands and makes of ventilators that we're seeing being donated to us. And then also reusing everything from PPE to CPAP masks, wiping down CPAP masks for patients who move on to be intubated or who are able to be weaned. You name it, we're trying to reuse everything. There are also challenges of press coverage. So, administrative and leadership issues surrounding, leaks and whistleblowers to the media. And I know a lot of you have seen a lot of coverage of our hospital, on CNN and ABC and other places as well. So that creates some stress between providers and leadership. And then even considering the ethics of DNR initiation and consideration of exclusions from ACLS based on a variety of factors such as age and potential futility and lack of ventilators. Citywide, as of Monday morning, in our system, we had over 1,250 COVID positive patients in our hospitals, which doesn't account for the patients who are PUIs who are probably also COVID positive, and as well as over 250 ICU patients in the system who are COVID positive. And so lastly, I just thought I would touch on coping mechanisms. So, there are a variety of things that we've done as a group to cope. We've been fortunate enough to receive lots of donations in terms of homemade masks, homemade shields, people showing up to the ED, dropping stuff off, taking pictures with us, saying good luck. and we actually have a lot of material in that way. Unused CPAP machines are another donation we've seen. Some widows of our prior patients have said, look, I'm not, we don't need the CPAP machine anymore, here, give it a try. We've had varying success with those CPAP machines, but it's definitely the thought that counts. We've received tons of gifts in terms of food, and we jokingly talk about the COVID-19 as the 19 pounds you put on eating free cheese pizza while taking care of COVID patients. Our ED has received cards from kids to sort of cheer us up between shifts as we walk out of the ED. And then also in New York City at 7 p.m. every night, there's cheering that can be heard across the town in terms of people who are cheering us on, walking to our shifts, getting on the subway. So that's very inspirational. So thanks everybody for listening. I think I'll wrap up my comments there. Hopefully this was somewhat helpful to some of you. Queens and Brooklyn are getting the worst of this in New York City so far. And I hope that the majority of those listening in other parts of the United States and other parts of the world don't have to go through the same challenges that we're experiencing. But just know that if you do, that we're all part of a community and we're all in this together.
Alex, thank you for your leadership and comments. Our next speaker is Dr. Cameron Siddell. Again, I apologize for going over late. It'd be probably 10 minutes late. This was being recorded. Type your questions to me as a host or to everyone, and then we can answer those questions either today or at a later time. Dr. Siddell is New York City. Dr. Siddell is an intensivist and emergency physician, and has some particularly interesting observations that he wanted to share with us, which I believe will also lead to on another Wednesday with a larger group of colleagues on this topic. Dr. Siddell, let me make sure you're unmuted.
Can you hear me?
Go ahead, thank you.
Okay, thank you very much. It's an honor to speak, and Dr. Manini, I feel like we are right there with you, and Dr. Lonati gives me shivers because I feel like we're about 3 weeks behind you, and possibly in a country with the medical system being more of a conglomeration of separate entities that may be less equipped to deal with this sort of large-scale disaster. I hope that's not the case. What I would like to talk about are some of my clinical observations that I hope may inform those who are either not at the bedside every day, or those who in the rest of the country who will soon be at the bedside every day, but may not be yet. I'll make it quick, but I'll try to do it through one case I had. And I will just say that one thing that's remarkable about this clinical entity is its uniformity. There seems to be almost a singular path that most of the patients take, which begins with them coming in hypoxemic, remarkably tolerating a hypoxemia until it progresses, until they need intubation, and then go on an almost universal, not completely universal, but very common pathway leading to renal failure, edema, and cardiac conditions. So the patient I'll speak about is someone who we put on high flow in the face of Italy having what appears to be about a 80% mortality or a failure of extubation rate. We initially were trying as hard as we can not to intubate these patients. But we needed a trigger. We needed a trigger in order to intubate a patient. And that trigger, we had decided arbitrarily, this was very early in our experience, it's still early in our experience, was when they required 80% high flow to achieve a SAT of 88 to 90. Now, anyone who has dealt with these patients is probably highly perplexed about how remarkably they can tolerate a level of hypoxemia that we are not used to. So our patient, this particular patient who was in her 50s with very little medical problems, we went over to discuss intubation. And she had no respiratory distress. She complained of raging fevers, and she felt terrible, as most of them do. But she did not have any respiratory distress, and she refused intubation. She did not feel like she needed it, and for us as a clinician, with staring into the face of a highly intervention that is, from everyone else's experience, suggests a high mortality. we didn't intubate her. And she asked that we do everything we can to not intubate her and only do it when we absolutely really had to. You know, now I was an emergency physician for a long time. I've done a critical care fellowship, and I always considered myself to be fairly adept at understanding when someone absolutely requires it, when they're going into respiratory failure. And for the next 2 days, we spent a lot of time with her, proning her on high flow and doing various things. And it was an extremely perplexing process, because to determine when she needed it was nothing like anything I've ever seen. And eventually, she got progressively more hypoxemic to the point where she was saturating in the high 60s on max high flow, and we decided that this was absolutely time to do it. And she called her husband. She was able to speak and explain what was going on. And then we intubated her and put her on the vent. Now, everything I have seen, including patients that we did not intubate because they had very lots of comorbid conditions and were unlikely to survive, you know, a 10 to 14 day vent run, suggests that there may be a possibility that we are dealing with a disease that we have never seen. You know, and in speaking with doctors around the country, there seems to be something about this clinical syndrome which I personally have never ever seen before. And as opposed to patients that are going into respiratory failure, meaning they are fatiguing their respiratory muscles, which is typical of you know, pneumonia leading to ARDS, influenza leading to ARDS, pancreatitis leading to inflammatory state leading to ARDS. These patients, as far as I can see, do not experience respiratory fatigue. This seems to be a pure hypoxemic failure, which is a very difficult and strange thing as a clinician to be countered with. In general, you know, it seems to me, and this is just my clinical observation, part of the reason I wanted to speak, because I very much look forward to responses and to hear about the experience from everyone, including, you know, our Italian colleagues who have a lot more experience than us. But this condition seems to, at least clinically, at least the syndrome, the constellation of symptoms, seems to most mirror that of, you know, either decompression pulmonary sickness or high altitude sickness. And when you speak to these patients at the bedside, they simply don't have the overt shortness of breath and respiratory fatigue one would expect with an alveolar condition. That is to say, with a condition whereby, you know, their alveoli are either filled up with you know, pus or fluid or some other thing worsening their compliance. So then if you look at the recent letter written by Gattinoni, you know, obviously everyone knows one of the legends of ARDS, he suggests most recently on March 30th, it was published, I think it was put out on March 27th, that really we're dealing with a high compliance condition in which the people seem to do the best on liberal tidal volumes, a high FiO2, and with the least amount of PEEP possible. Now, in general, that is 100% opposite of the approach we traditionally take in ARDS. And from what I have seen at the bedside, there seems to be a somewhat temporal correlation between when we intubate them and when they go into multi-organ failure. Now, there's a very valid argument that their disease process is worsening. And so we are intubating them at a very severe state of their disease, and perhaps they would have gone into multi-organ failure anyway. But I would just ask those that are bedside, there seems to be somewhat of an exaggerated, even more than one would expect, in the relationship between when they're put on the vent and when they go hypotensive and when they go into renal failure and eventually get cardiac conditions. And, you know, this refers to sort of one of my fears, which is it possible, is it at all possible that this disease, COVID-19, or you can say the lung aspect of COVID-19, is not inherently linked to acute respiratory distress syndrome. Could it even be possible that what we are seeing may be a complication of the high pressures we are inevitably using with a severely hypoxemic condition in order to obtain saturations that we find adequate? Which is to say, is it possible that in short, we are causing lung injury as we are trying to save these patients? And this is not something I have an answer for, but the findings by Gattinoni and from everything else I'm reading suggest that we need to at least open our minds to the possibility, primarily because that means that the interventions we are using, we may be using in a stage too late, whereby the cytokine response we are seeing may not necessarily be related to the natural course of the disease, but may be related to the course of one of our primary interventions. So I don't have an answer for this, and I hope to get responses, and I hope it will at least inform and stimulate some thoughts away from here. And I really do. I thank you for listening, and thank you for your time.
Dr. Sedell, this is really touching and insightful observations. I hope this can generate additional thoughts and questions way beyond this this session today. I want to thank all our panelists as well as our speakers, and I'm going to take a few questions that came through the chat box. Please feel free to send more questions. Just in case I lose some of you, I just want to remind you this is being recorded and will be available in the next 48 hours on our website, as well as the slides, and hopefully a briefer podcast summarizing discussions. Some of the questions that came through here refer to the earlier presentations, and one of them is regarding the ACE2 inhibitor, or the ACE2 receptors. Any idea how long it takes to upregulate or downregulate ACE2 receptors? And I'm going to go ahead and unmute Ryan, I think, for this one, or Josh.
Ryan, feel free to answer if you know the answer. I do not. The short answer is that if you're looking at how long it takes to upregulate and downregulate ACE1, if it follows a similar course, it's a very short period of time.
I know in the NSAID studies, it was 7 days to 8 weeks that they were actually studying them. So that's one of the concerns that we don't know what acute use of NSAID. Is that enough one time to actually begin upregulation?
Thank you, Ryan. What about favipiravir? This is a question to Dr. Davis. Are there any trials on favipiravir in the United States? If given early, would it help prevent viral replication early?
I'm sorry, could you say that one more time?
The question is regarding favipiravir and if it's actually been studied for COVID-19.
Oh, for favipiravir? To my knowledge, there is no U.S. Trials enrolling currently. There is an international WHO trial that has a multi-treatment arm comparison, but I don't believe favipiravir is one of the agents under study right now.
Very good, thank you. And then what about acetaminophen with remdesivir? Are there any issues between the two?
Oh, that's a great question. Yeah, so from the study protocols that I've received, so our site is an enrolling site for the adaptive COVID-19 trial. That does preclude concomitant acetaminophen use up to day 15 of treatment. And I think that's for two reasons, really. It's first and foremost to avoid concomitant hepatotoxins, to reduce the risk of hepatotoxicity in general. But also, I think it's probably to have to eliminate confounding signals when they're going back and analyzing the safety data later on.
I think Dr. Sedell and Dr. Manini, at which PaO2 are you intubating the patients and then field been tried? And it's beautiful to see all these questions coming from all over the world, by the way. We have questions from Venezuela, from Iran. It's really touching to see this international effort. So again, the question, Dr. Sedell, is about sildenafil And what PaO2 would you intubate on, as well as Dr. Manini, if you're still there?
So we have not used sildenafil. We've certainly talked about it, as well as other pulmonary vasodilators. This being, especially in light of Gattinoni's observation that this seems to be a condition primarily dealing with hypoxic regional vasoconstriction. So certainly there's a theoretical aspect for this working. As far as their PaO2s, prior to being intubated, we initially were getting ABGs, but I can tell you from our anecdotal experience, they very well seem to correlate with their saturations. So they're, one of the clinical findings that we see is, for example, when we intubate them and they desat to very low levels very quickly, often their heart rate doesn't seem to change. And there was a thought that there must be some, it was so unusual that we thought that there must be some discrepancy between their PaO2 and the saturations we're seeing on the monitor. What we have found is that's not true, that they actually do correlate very well. So as far as when we intubate them, it's very much a moving target. What we initially were doing, as I mentioned before, was we said that when they required 80% high flow to achieve 88 or 90, we would do that. And then we had some patients that did better and never needed intubation. And so, our recent target, and this is very fluid, and it may change tomorrow, and this cannot be done unless it's in an ICU, because these people tend to be entirely dependent on oxygen, is that when they required 90% high flow to achieve 88 to 90 and appeared in distress, which is generally comes in the form of tachypnea and anxiety. However, we have had patients that went down to the 70s and still did not have tachypnea and anxiety. And at least my feeling is that those patients do appear to be at risk. But this is the very question that we are trying, I'd say of all the questions that we're trying to decide is, in the face of such a high mortality for mechanical ventilation, when is the right time to do it? And I'd say that is what is most distressing to us as clinicians, and the thing that we are most trying to figure out.
Dr. Manini, do you have anything else to add to this? And while you get ready to add something, the other question I have is regarding interferon, as well as avoiding propofol because of its theoretical chelation of zinc. So propofol as a sedative, and then interferon. Alex, do you have anything to add regarding the first question? And does anyone else have anything to add regarding those questions of propofol, as well as interferon?
This is Matt Davis. In regards to the interferon, I can't really comment too much on propofol. That's a little bit outside of my wheelhouse as ID pharmacist. But for interferon, there has been some interest with various interferons in a number of different zoonotic coronaviruses, including MERS, SARS-CoV-1, and then also SARS-CoV-2. It's been explored predominantly in China. The Chinese national guidelines actually are recommending inhaled interferon alpha kind of as one of their standard of care regimens. A lot of the colleagues here in the stateside have not really adopted that practice to include interferon as a treatment option. And this is really kind of a risk-benefit calculation. They're unquestionably highly toxic for patients. And the data for supporting their efficacy is not really as strong as we'd like to see in order to make it kind of a mainstay of therapy.
Are they testing healthcare providers for infection or antibodies, past infection?
No, in Italy, the test for antibody is under study, but there is not a validate testing for this aim. And we have different approach because the health system in Italy is managed by region, every region. And for example, in Veneto, Veneto decided to test all asymptomatic or paucisymptomatic patients. In my region, in Lombardy, no, only symptomatic patient, and since 5 days, all personnel that work in hospital and that is symptomatic is tested for COVID-19.
Thank you. What about prednisone, Dr. Sedel? What's your comment on the use of prednisolone for ARDS? And what is the outcome of the patient you presented kindly?
The patient still remains on mechanical ventilation in our ICU. She progresses. Most of the patients progressed. Especially early. We were doing, which is standard for ARDS protocol. We were providing fairly high PEEPs to achieve saturations of 88, 90. So she got up to 18, 20 of PEEP, and inevitably, like most of the patients we're seeing, progress from a state of high compliance to a state of low compliance, and what I would say it seems to be full-blown traditional ARDS. As far as prednisolone or steroids, now we're in a state where we're having some patients who are getting secondary infections, and we're generally sort of following the surviving sepsis guidelines, which is to say if they appear to be in shock, then we're considering it, but it's generally not part of the first line treatment for patients, certainly when they're not intubated and if they don't display signs of shock.
Excellent. Thank you again. With that, I think it's time to conclude our session today. Apologize if I did not get to all the questions, and we will get to them by email. And again, thank you. Remember to join us next week. Mark your calendar for Wednesday, April 8th, 3 p.m. Eastern Daylight Saving Time. The title is being still, and the topic is still being developed. Expect that by Monday morning. We do this on purpose because we know this is a rapidly evolving situation, and we want to bring to you the latest from the front, as well as the latest topics that are being introduced to our plate and are relevant in our fight of this virus and this pandemic. I really want to thank everyone who participated in organizing this event, including our societies in toxicology and emergency medicine, and hope you will join us again and view the webinar and the slides at your leisure. Thank you.